Dr. Paulette, if you could please take it away. Thank you.
All right. Thank you very much. Good afternoon. I'm Aaron Paulette, the Provincial Head for the Pathology and Laboratory Medicine Program at Cancer Ontario. On behalf of Cancer Care Ontario, the Canadian Partnership Against Cancer, the Canadian Association of Pathologists, I would like to welcome everyone to today's CAP Checklist education session on colorectal cancer, focusing in on serosa issues. Go to our speaker and we get underway. A few housekeeping items. This session, first, this session is being recorded and will be made available to all participants. Links once the recording is available online. Both live presentation are eligible for C credits. The was in the notice for this session. Please see me. Each education sessions will one from the presentation date. Please refer to the session notice for the exact deadline. Because everyone's line has been automatically muted for today's presentation. Have difficulty issues. Having difficulties, please call the WebEx support line 86229-339. We encourage you to submit questions at any time during the presentation using the chat feature. The documentation previously distributed provides instructions for using the WebEx chat window. During the question and answer portion of the presentation, in order to avoid collision, we'll pose the submitted questions on your longest heads and the order in which they appear. Window, please include the following information: your institution's name, the individual posing the question, and the question itself. Pleasure to introduce Dr. Jeremy Parfitt. Parfitt obtained his also completed his residency in he completed a fellowship in gastrointestinal, pancreas, and liver pathology, splitting his time between London, Ontario, and the United Kingdom. An associate professor at Western University, where he practices at London Health Sciences with a in GI pathology. He is active in research in the area of GI pathology and has published approximately 40 peer-reviewed articles and book chapters, where he's the primary author on more than 20 of former winner of the Roger Cotton Histopathology Prize, the best published paper in the Journal of Histopathology. His GI pathology-related speaking engagements include and national events, including the CAP Annual Residence Review course and several rounds held throughout the province. Some of the other responsibilities in community work includes being principal investigator for the London branch of the OICR Ontario Tumor Bank, serving on the OMA Laboratory and Section Council. All this when he's not working, he does enjoy spending time with his wife and 4 children. With you, I am pleased to introduce Dr. Parfitt.
Thank you, Dr. Paulette, for that kind introduction, and welcome everyone to this on the colorectal cancer checklist. No conflicts of interest to declare. Presentation, I'll be reviewing selected prognosticators that show up in the colorectal cancer checklist. Specifically to talk about serosal surfaces and radial margins. So I'll spend most of my time talking about those 2 issues, but I will also talk about vascular invasion, tumor differentiation, and tumor deposit. These presentations are always challenging because obviously there's a lot of things on the checklist that could be discussed, and I think there's interest or questions about some other things that could perhaps be handled during the Q&A portion, time permitting. So my sources that I've used to prepare this presentation are the AJCC TM version 7, which came out in 2010. The American Pathologist Protocol, actually just last updated at the end of January this year, 2016.
Hi, Dr. Parfitt. This is Jean. Could you just hold on a moment? We've lost your presentation, so if you could just hold on a moment, please.
Sure.
Oh, if you could just make it a full screen. Thank you. Thank you. We're back on track. Thank you.
Okay. So in addition to the CAP checklist, I also will give some complementary information, just data set, where the UK guide last in 2014. There is some complementary information there. Some caution needs to be used, since they still use the TNM5 system. And then I'll also refer to just a select number of relevant articles that inform the guidelines. Another thought this presentation could be framed was a question: who gets adjuvant therapy? In clinical stage groupings, say for 3 of the 4 clinical stage groupings, there's very concrete answers to that. However, for clinical stage 2 disease, those are patients with T3 and 4 tumors without lymph node or distant metastases. The question becomes a little bit more interesting, perhaps controversial. The guideline is that patients with clinical stage 2 disease generally not be given adjuvant therapy, as only a small percentage, less than 5%, actually see some benefit. However, in reality, it's clear from the oncology literature, and even just from speaking with our oncology colleagues, for patients with clinical stage 2 disease actually do wind up being offered and given adjuvant chemotherapy. Is that? There are guidelines put out by the American Society of Clinical Oncology, as well as the network, to list a number of variables, most of which are pathological variables that we report in our synoptic checklists. The group is called high-risk stage 2 patients. All of these things are to cause a worse clinical outcome due to more accelerated course of tumor recurrence. So I'll handle the first 5 items on this sort of summary list that I've compiled. And again, if there's interest in some of the other things, perhaps they could be Q&A. So what I'll make is that a serosal surface, not the same as a radial margin, yet there continues to be some confusion around these. We've probably all seen close descriptions where the terminology seems confused. What is the serosa? Well, serosa is a mesothelial-lined, peritonealized surface that invests or partly invests the visceral organs. The abdominal cavity, that includes the colon, as well as to some degree the mid and upper portions of the rectum. Serosa is a normal anatomical structure. As such, inking is generally not recommended. It's certainly not recommended in either the CAP checklist or the RC path. In fact, discouraged. Why interest in serosal surfaces? Well, the reason is invasion, one of the strongest predictors of particularly peritoneal tumor recurrence and deep survival in colon cancer. Its application in rectal cancer as well, but its primary importance seems to be within colon cancer. 2016 updated CAP guidelines for how to know serosal invasion. 3 criteria are listed, of which, if present, would signify serosal invasion, is what defines the PT4A category. I won't specifically be talking about PT4B disease, which refers to invasion of adjacent organs and structures, but the questions about that perhaps later. For serosal invasion, the first item is tumor present at the serosal surface. The second criterion is free tumor cells on the serosal surface with an underlying serosal erosion or serosal reaction of some sort. Thirdly is perforation in which tumor cells are contained through inflammation. And I'll highlight a couple of potentially misleading and confusing things here. This is the word on in the second item, free tumor cells on the serosal surface. I don't think that necessarily means that tumor cells have to be stuck on or even touching the serosa in the peritoneal cavity, and I'll explain why. The third item, perforation, in which tumor cells are continuous with the serosa through inflammation. It's not expressly stated whether that is just gross tumor perforation or that could be a purely microscopic finding. And I would argue that it could be a purely microscopic finding. Tumor cells communicating through, for instance, through the serosa, then also could fulfill the criteria for T4A disease. Hopefully there won't be confusion about a grossly perforated tumor. A grossly perforated tumor is an automatic PT4A. It is a poor prognosis. To be confused with perforation away from the tumor, which has no effect on the T stage, but albeit does have an impact on perioperative mortality. So one of the papers, and one of the few papers I'll go into detail on, is a paper by Shepherd's group in the UK. It's really a critical paper to understand how we define serosal invasion. It's really where we get our definition of serosal invasion. In this study, they looked at over 400 colonic cancers and tested them in a meticulous way. They took at least 2 sections where tumor was closest to the serosa. Logically, tumor was close to serosa. They performed step sections to try to demonstrate serosal invasion. Divided their cases into these 4 groups, LPI 1 through 4, where LPI stands for local peritoneal or serosal invasion. Their LPI 1 group was tumor well clear of the peritoneum. Their LPI 2 group was tumor close to the peritoneum with associated serosal reaction. And importantly, their LPI 3 and 4 groups are very important for us. Their LPI 3 group was about a quarter of their cases were present at the peritoneum with the serosal reaction. That should that's where we're getting our first criterion of tumor present at the serosal surface. LPI 4 group, which constitute about a third of the cases, was tumor cells free in the peritoneum with adjacent serosal erosion. And it should be clear that that's where I think we're getting the same criterion of free tumor cells. The study, they also had clinical outcome data where they showed their LPI 3 and LPI 4 group have significantly worse survival probability. And took their LPI 3 group and LPI 4 group, lumping them together to define what they would call or consider serosal invasion and T4 disease. at least four important conclusions from this study. The first is that local peritoneal invasion was the strongest predictor of poor outcome, even ahead of invasion of adjacent organs and structures, even ahead of lymph node mets. And in fact, in earlier versions of TNM, that was the rationale for making serosal invasion for B disease. In the current edition, TNM7 is T for A disease, larger sets from the U.S. Which is that local peritoneal invasion was common. In fact, more than 50% of their colon cancers showed serosal invasion. Third point, that their LPI4 group and LPI3 group were not really equal in terms of prognostic power. It would be clear that the LPI4 group, even more significantly predicted peritoneal recurrence and poor survival. I think it's important because if you read the articles from Shepherd very carefully and look at the pictures, it becomes clear that these free-floating tumor cells are potentially free-floating in the peritoneal cavity, like in the white space, not necessarily on the serosal surface, not necessarily touching the serosa in any way. I defend this concept in subsequent papers. And then fourthly, local peritoneal invasion was, we might have lost the presentation again.
Yes, Dr. Parfitt, if you could please bring back up your presentation.
Okay.
Just one moment, please. Yes, please go ahead.
Okay, so last serosal invasion was very strongly correlated with mucinous adenocarcinomas. Shepherd's group also had a complementary paper looking at rectal cancers, in which a quarter of rectal cancers also showed serosal invasion. Those were rectal cancers above the peritoneal reflection, and similar predictability for tumor recurrence and peritoneal spread. So here's an example of what would have been the LPI3 group, where we have tumor glands at the serosal surface with an associated serosal erosion or reaction. So that's no problem. That's a kind of an easy PT4A disease. To illustrate the difference between the LPI4 and 3 groups, if you free-floating tumor cells in the peritoneal cavity, just floating in the white space, would be their LPI4 group. It is a PT4A lesion, and they're having higher predictive power for peritoneal recurrence. I have an example of tumor glands present very close to a serosal reaction. This will correspond to Shepherd's LPI2 group. The current guidelines, we call this a PT tumor. There are some extra suggested to take that I'll mention. And highlight, if stuck in tumor cells on the other side of this serosal reaction, that would change, that would be the T category altogether, the T4A, and this lesion would be at particularly high risk of peritoneal recurrence. Adenocarcinomas have a high serosal lesion, and useful is that you have tumor cells anywhere within a mucin pool that is communicating with the serosal surface. I think this should qualify as PT4A disease and serosal invasion. It's essentially analogous to having tumor cells communicating through a microabscess to the serosa. The tumor cell is not right at the serosa, or anywhere within the mucin pool, communicating with the serosa, then I get serosal invasion. I'll look at some things provided in the RCPath data set from the UK. They state that at least 2 blocks of serosal nearest to the tumor should be obtained for assessment. Some macroscopic clues such as a dull or hyperemic appearance, as seen here with this upper rectal tumor of the anterior peritoneal reflection, where we're puckering, a bit of a dull appearance and hyperemia. That's suspicious for serosal invasion, and it highlights the problem that if you ink that, you could potentially obscure some of those findings. They pointed out that clustered areas in the serosa were at particularly high risk. You can see that here at the white arrows and in this whole mount. At the base of these deep serosal clefts, they're kind of like hot spots for serosal invasion. Guidelines recommend that if tumors very close to the form leveled sections, and they also make the point that it's only purely inflammation that separates the tumor from a serosal, then you can T4. This agrees with what we're seeing in that third item of the checklist. Guidelines are also helpful to suggest some reporting benchmarks. They say that you're reporting serosal invasion in at least 20% of colon cancer and at least 10% of rectal cancer. And from the studies, those are underestimates by about twofold. There has been some interest in elastin staining to demonstrate invasion of a subperitoneal elastic lamina to the colon. However, the problem is that there's really only a handful of these studies, and they seem to show somewhat contradictory results. There's a couple of papers that suggest it's useful to highlight or identify a group of high-risk PT3 tumors. Other studies have not been able to reproduce that prognostic power. And in fact, more than one study have highlighted some practicality issues that it seems that in around 50% of cases, by performing elastin stains to try to highlight this like lamina, analogous to assessing pleural invasion in lung cancer, but in about half of cases, the elastic lamina is either absent or continuous and difficult to assess. So, but is that neither the RC path dataset nor the CAP checklist recommends this procedure. Challenges that remain. PT4A disease, the problem is generally one of under-recognition and under-reporting. There is some controversy around the actual definition of PT4A disease. It comes from this paper by Panarelli et al. In ASP 2013, where in addition to performing conventional histopathology, they did an ancillary test where they did serosal scrapings and did cytology preps to identify tumor cells in these serosal scrapings. Provocatively, what they found was that about half of deeply invasive PT3 tumors that were a million or less from a serosal reaction actual tumor cells in these serosal scrapings. And that was a nearly identical number of results as what they found when they did the same thing with logically designated PT4A tumors. Now, to make it worse, they also had some clinical follow-up data. They showed a pretty similar rate of peritoneal recurrence for deeply invasive PT3 tumors, a millimeter or less from a serosal reaction, compared with true PT4A tumors. So there's, we're calling for an expansion of the PT4A category to include these. However, I think the recommendations are still clear from both the CAP checklist and agrees with the RC path dataset. That you have a deeply invasive PT3 tumor, a millimeter from a serosal reaction. You should cut levels. You consider obtaining those sections to demonstrate true serosal invasion. But if at the end of the day you can't do it, call it a PT3 tumor and perhaps give a comment in your report something to the effect that although definite serosal invasion is not seen, features to suggest that there may be an increased risk of peritoneal spread. That's a fair resolution. And just keep this caveat in mind that no stroma between tumor and serosa. Either tumor cells are communicating through a microabscess,
Dr. Parfitt, yes, we've lost your presentation again.
Back up.
Thank you.
Okay. So if there is no stroma between tumor and serosa, tumor cells communicating through pure inflammation or mucin, then I think in that situation you could call it PT4A. So next I'm going to talk about radial margins. And one point I'll make that I know will annoy some purists in the audience is that from reviewing the guidelines of various sources and the literature, it seems to me circular radial margin or CRM and radial margin are basically just used synonymously and interchangeably. And some purists will say that, well, it's really only below the anterior peritoneal reflection of the rectum, the truly circumferential radial margin. That's true. For all intents and purposes, the terms CRM and radial margin just used synonymously. The radial margin, well, it's a soft tissue, non-peritonealized surface that's being surgically cut. Colon is typically often through blunt dissection. In the room with a mesothelial excision is usually with sharp instrumentation. It's a true surgically cut resection margin, and as such, it should be inked. Why interest in radial margins? Well, particularly rectal cancer, RM positivity has been known to be the strongest predictor of local recurrence rectal cancer, and it's also predictive of distant metastases and survival. So it's have an application in colon cancer as well, but it's a particularly big deal in rectal cancer. If the CRM is to rectal cancer what the serosa is to colon cancer. It should be clear that all colorectal cancer specimens have a radial margin. It's just their appearance and their nature vary depending where you are in the large bowel. So if you're in the ascending and descending colon, along its posterior aspect, there will be a retroperitoneal bare area, black serosa, that constitutes the the radial margin, if you will, the CRM. Lower rectum, below the anterior peritoneal reflection, the one spot that you have a true 360-degree circumferential radial margin lacking serosa. And it should be stated that in the mid and upper rectum, the situation is really more analogous to what we might see in the ascending and descending colon, where you have basically a retroperitoneal bare area posterolaterally. To the transverse and sigmoid colon, and usually the cecum, although there's some variation to the anatomy there. Those portions of the bowel are almost entirely encased by serosa, and so in those cases, your radial margin becomes this narrow mesenteric tied-off pedicle margin that becomes the radial margin. This was even more of what constitutes a positive radial margin. So it's now the international standard to call a positive radial margin according to the 1 millimeter rule. This applies to both rectal cancer and colon cancer, and a positive radial margin is defined as tumor that's 1 millimeter or less from the inked non-peritonealized surface. It should be recognized that you can have a radial margin due to a variety of different scenarios. In addition to direct tumor extension, you can have a positive radial margin due to discontinuous tumor deposits. You can even have a positive radial margin due to tumor within vascular spaces, which is interesting because within vascular spaces have no effect on T stage, but it can give you a positive radial margin. And in fact, even if you have tumor within a lymph node, if the tumor cells are a millimeter or less from the non-peritonealized cut surface, then that would constitute the radial margin. Now, it should be noted as a caveat that according to one study from the Netherlands, that if you do have a radial margin that's due to tumor within a lymph node, it seems like the prognostic significance is actually not the same, not great as it would be in other scenarios. So it's recommended that if you do have a positive radial margin that's due to tumor within a lymph node or vascular space, you should mention this in your report and perhaps handle the nuance in a comment. You have to talk about total mesorectal excisions in the context of radial margins. A total mesorectal excision is a specialized surgery for rectal cancer, removal of so-called Waldeier's fascia, a soft tissue mesorectal envelope which encases the rectum and contains all of the regional lymph nodes. By the surgeon using sharp dissection in a fascial plane just outside the visceral mesorectal fascia, the so-called holy plane. Because over the last 2 decades, numerous studies have really proven a clinical benefit by showing decreased local recurrence, increased 5-year survival on the order of about 20%. Total mesorectal excisions, or TMEs, have really become the standard of care surgically for rectal cancer. Now, on our side, for pathologists, it's also become the standard of care to perform a macroscopic assessment of the quality of the TME specimen. There are randomized controlled trials that show that this pathological macroscopic assessment of the quality of the rectum is itself predictive of local recurrence and survival. And one of those unique areas in pathology where the pathologist's role in providing direct feedback to the surgeon about the quality of his surgical technique actually led to improvements in surgical technique. As a consequence, real improvements in clinical outcomes. So it's an area of pathology where pathologists have made an impact on clinical outcomes. The most ideal way to assess a TME specimen is according to the method that's being used and pioneered and promoted by Professor Quirk in the UK. There are 3 designations on its macroscopic assessment: a complete, nearly complete, and incomplete, and then another assessment is performed after fixation on cross-sectional slices. Some examples of each. There's some excellent photos that I've taken and are available in RCPath data sets, and you see those on their website. When evaluating a mesorectum, you're looking at 3 variables. You're looking at mesorectal bulk, surface defects, and distal coning. I would submit to you that mesorectal bulk and coning are kind of objective measures that are going to be susceptible to inter-rater variation. As I would commend to you the importance of the surface defects as a more objective and robust observation that hold up better to inter-rater reliability. In fact, locally, I've been doing a study on inter-rater variation and reliability for assessing mesorectums. As one thing we are finding is that surface defects, in particular, are a robust and reliable way of distinguishing between the categories. For a complete mesorectum, there are no surface defects greater than 5 millimeters in depth. For a complete specimen, there will be less bulk, perhaps some coning, but importantly, there will be surface defects that are deeper than 5 millimeters when measured with a ruler. but importantly, there will be no areas of direct visibility of the muscularis propria. Yet, for that is that you should be aware of abdominal peritoneal resections. In the APR specimen, the insertion site of the levator muscles, there is a normal and acceptable area of so-called surgical waste. You may see some muscle there too of the levators or sphincter muscles that don't count for so mesorectum has a kind of ragged and actually has little bulk. Certainly, there will be defects right down to the muscularis propria, and they usually be seen. You can see that here. It's usually kind of a striated appearance due to the bands of longitudinal muscle of the muscularis propria. So it's the kind of specimen here that has a high rate of CRM positivity, and so a high rate of local recurrence and poor outcome. Handling a TME specimen, it's important to locate certain landmarks. In particular, anteriorly, you want to identify your anterior peritoneal reflection. This is the lowest point of serosa in the post, basically, above which is shiny serosa, and below which is the truly circumferential radial margin, lacking serosa. So once you've done this, it's recommended to classify the location of a rectal cancer with respect to that anterior peritoneal reflection. And the rationale and reason for this is mainly because we have tumors that are below your peritoneal reflection have a worse prognosis because they tend to have a higher rate of CRM positivity, and that part of the specimen is susceptible to suffering from mesenteric defects and coning. It is recommended to ink the circumferential radial margin, which below the serosal, the anterior peritoneal reflection, is in a 360-degree fashion, above which, and looking posteriorly, really more analogous to a retroperitoneal area posterolaterally. Doing this, according to Quirk's method, you open the specimen partially along its anterior aspect. The specimen intact, though, for a distance of 1 to 2 centimeters above and below the level of the tumor. Use gauze wicks above and below, and then leave it for fixation intact like this several days. Now, in terms of how many days, there really are no hard and fast, universally accepted criteria. Professor Quirk say that he likes it to fix for like 4 or 5 days. RC Path data set, it says it should fix for at least 24 to 48 hours. That checklist is basically silent on this. Here in Ontario, we have from Ontario, it should fix for at least 72 hours. And that seems right and reasonable to me as well. The thing is that the longer you fix it, the easier this next step is going to be. So in this next step, you serially section the intact portion. These cross-sectional slices, you lay them out with proper orientation as to proximal versus distal, anterior versus posterior. It's convenient to use 4 millimeters thickness for the slices, which is about block thickness for taking your sections. And you should reassess the circumferential radial margin. In particular, in this case, you can see that anterolaterally, the CRM looks disrupted and irregular. Use measurements of the closest distance from tumor to the radial margin. You take a measurement of the closest distance for any grossly positive lymph nodes to the radial margin. And it's also recommended to state whether the closest radial margin is anterior, posterior, or lateral. You can consider photography. That's not spelled at all in the CAP checklist, but it's certainly helpful when doing microscopy to have a photo like this to refer to. I think it also would be helpful in situations where you're going to be providing negative feedback to you about the poor quality of the TME they produced. It's also helpful for radiologists who are looking at MRI images, which actually correlate very nicely with a picture like this. So you take at least 2 to 3 blocks of tumor nearest to the closest radial margin, admit all the lymph nodes. It should be noted that with this quirk method, some care does need to be taken not to double count lymph nodes that might be in more than one slice. Admit all the lymph nodes. You should certainly submit all negative and equivocal lymph nodes in their entirety, acceptable for a load to admit a representative section. And certainly if you have a suspicious lymph node that's close to a CRM, leave it intact in the block so that can be reassessed by microscopy. And not to forget, the first part of this talk, that if you have a tumor that's located either straddling the anterior peritoneal reflection or above the periflexion, then you need to take appropriate sections for serosal invasion too. Talk about vascular invasion, and the first point I'll make that lymphavascular invasion is not the same thing as venous invasion. And certainly is not well appreciated by some of our clinical colleagues on the oncology and surgical side, and certainly even in high-profile recent oncology articles, lymphavascular invasion is not well delineated from venous invasion. Last version of the CAP checklist, the 2013 version, this didn't appear. The reality is there are 2 types of vascular invasion. There's lymphavascular invasion and there's venous invasion. A lymphavascular space is a thin-walled endothelial space that lacks a smooth muscle layer or elastic lamina. Lymphavascular invasion has really long been associated with lymph node metastases and decreased survival. And a vein has a smooth muscle layer or an elastic lamina. And more recent literature, venous invasion has really emerged as a very strong independent prognostic factor predicting liver metastases and mortality. Whereas venous invasion, hematomas, lymphatic invasion predicts lymphatic mets. It should be noted that it's recommended to report extramural venous invasion separately from intramural venous invasion. That's because extramural venous invasion thus far really appears to be the stronger predictor of liver mets and mortality. The EPAT dataset provides some reporting benchmarks. They say that you should be reporting venous invasion in at least 30% of cases, and I'll show you that that also is an underestimate. So just to dispel another myth, here you have an example of lymphovascular space invasion into an uninvolved vein. I just make the point that the concept of small vessel invasion versus large vessel invasion is potentially erroneous. We could have a case of lymphovascular space invasion which is bigger than the muscularized vein. So it's not size, it's the presence of a muscular coat or elastin layer. Brings us to the issue of elastin staining for detecting venous invasion. And in this case, in contradistinction to the situation of elastin staining for assessing a surrogate marker of serosal invasion, where it's not really recommended, for the case of elastin staining for detecting venous invasion, it's highly recommended and actually really important. Studies have shown that routine elastin staining with venous invasion improves the detection rate less than 20% to over 50%. And I know that there will be skeptics that, like myself, might ask, well, just because we're detecting more of something with a special stain, maybe its predictive value is not the same. Well, it's true the predictive value is not the same, but it's actually opposite of what the skeptic might assume. That routine elastin staining to detect venous invasion actually improves upon its prognostic power. That's shown in these studies by Roxburgh et al. And importantly, it appears from these studies that the prognostic power of elastin staining detected venous invasion is as important as lymph node metastases for prognosticating colorectal cancer. Some diagnostic clues to look for on an H&E. There's the orphan artery sign and protruding tongue sign. The orphan artery sign, if you see a artery that appears unpaired with its vein, look for a cluster of tumor cells nearby and perform an elastin stain. This is a MOVAT stain. You'll often be able to demonstrate a circumferential pattern of elastin staining. We should make the point that you don't need to see endothelium, and you don't even need to see a muscular coat efficient to demonstrate the circumferential pattern of elastin staining to diagnose venous invasion. The protruding tongue sign is when you have an elongated nest of tumor. Looks like sticking out its tongue. It typically projects out at a somewhat perpendicular angle from the invasive tumor front, and typically protrudes out from the muscularis propria into subserosal fat. If you do an elastin stain, it's a MOVAT stain. In this case, you'll often be able to demonstrate venous invasion. So now to talk about tumor differentiation. Tumor has been around a long time, and yet it's still important because it's one of those items that's really cemented in the minds of our clinical colleagues. They understand, they know tumor differentiation. If it's poorly differentiated, I think that it behaves worse. And certainly, the literature has, proven that tumor-grade tumor differentiation does have prognostic value. You will see some 4-tier systems out there. That was in the AJCC staging manual, and you'll see some 2-tier systems out there. This is handled well in the most recent version of the CAP checklist, explaining why it's really recommended to use a 2-tier system rather than a 4-tier system. And is that most of the studies that have proven the prognostic power of tumor differentiation have essentially taken 4-tier systems and collapsed them down into 2-tier systems. So recommended to use a 2-tier system. A poorly differentiated or high-grade cancer has less than 50% glandular architecture. There are some special types that are by definition high-grade. Important point I want to make is that if you do have a poorly differentiated tumor, you should at least consider the possibility of satellite instability. And going back to our framework of who might adjuvant therapy in clinical stage 2 disease, you imagine if it's a poorly differentiated tumor, that would make it a so-called high-risk stage 2 disease. And if it's an MSI tumor, it would be a low-risk stage 2 disease, because we know that MSI-H cancers have a better prognosis and actually respond less well to certain types of chemotherapy. A poorly differentiated tumor, you should just run through in your mind whether this might be an MSI tumor. So MSI tumors are often right-sided tumors. The characteristic histology may show medullary differentiation or mucinous differentiation. The hallmarks of MSI cancers is they often show intratumoral heterogeneity. Quite nicely here, on the hand of this photograph, we have a poorly differentiated area. In the middle, it appears more glandular. And the upper portion is showing that head is typical for an MSI cancer. The medullary pattern shows a solid architecture, sheet-like architecture, with tumor cells that often show round vesicular nuclei with prominent nucleoli. And importantly, they will typically show very prominent tumor-infiltrating lymphocytes, which I think you can appreciate well here. Any of this makes you suspicious that it's an MSI tumor. You perform the appropriate MSI testing, even apart from the HNPCC screening implications. You should follow your local protocols. It usually involves, as a first step, misprepare protein into chemistry. So, lastly, and everybody's topic, is tumor deposits. Tumor deposits are actually one of those contentious issues in TNM7. Definition in TNM7 for deposits is discrete foci of tumor in pericolorectal that's away from the leading edge of the tumor, no residual lymph node tissue. Shown that tumor deposits are associated with poor outcome and survival. In the literature, it seems to be recognized that tumor deposits have a heterogeneous pathogenesis. In some cases, be discontinuous tumor growth, but in some cases, they might present venous invasion or lymphatic invasion, possibly outgrowing its vessel. In cases, it might replace a replaced lymph node. And it's important to sort of understand that, I think, because in some cases, it may be appropriate to perform elastin stain to pick up extramural venous invasion rather than a tumor deposit. In case, call it a venous invasion, not a tumor deposit. This is actually an trichrome stain here where you don't see an elastin stain is lacking here. So this is a tumor deposit. Sources of confusion is that in the last 3 versions of TNM, there's been 3 different definitions of a tumor deposit. In TNM5, it was the 3 millimeter rule. In TNM6, it was the rounded contour rule. And in TNM7, it is the no residual lymph node tissue rule. It should be pointed out that in previous versions of TNM, tumor deposits had the potential to affect the T category. Were not the case. In TNM7, tumors have no effect on the T category, but potentially have the ability to affect the N category. So in lack of other true lymph node mets, if you have tumor deposits, it's classified as N1C. And another thing I might just point out is that if you have a tumor deposit that is convincingly showing serosal involvement, it's actually neither a T consideration or an N consideration. I would actually best call that PM1B disease, a distant metastatic peritoneal disease. Obviously, this is a confusing topic. A couple of papers I will point out to you, as this provide that appeared in the Archives of Pathology Lab Medicine, entitled Debating Deposits. I took a collection of examples and a panel of expert GI pathologists and to assess whether it was a tumor deposit or a lymph node met, and assess inter-rater variation of our expert panel. Not very surprisingly, they actually found there was some inter-rater variation amongst the so-called experts. Surveyed the experts to ask them what feature they were using to help them recognize a lymph node, residual lymph node tissue. And interestingly, one of the top answers that was cited was a round shape, harkening back to the rounded contour rule of TNM6. Features listed were capsule, peripheral lymphocytes and follicles, subcapsular sinus. Another paper in 2015, Modern Pathology, the issue that, there's really no minimal distance criteria for a tumor deposit to be from the main tumor mass. It can be very close. And they made the argument that for tumor deposits that are less than a millimeter from the main tumor mass, if they actually perform some level sections on these, and in some cases we're able to demonstrate a hidden connection. And we're highlighting this potential pitfall that if the tumor deposit is very close to the main tumor mass, then you could potentially overcall a tumor deposit. And I think the reality is that's true. In that situation, you might even undercall T stage. So, pitfalls and confusion remain in the area of tumor deposits. So just to summarize, cell involvement, it's a very high impact adverse factor, particularly in colon cancer. Don't forget it in rectal cancer, but particularly in colon cancer. I'd be reporting this in at least 20% of cases with careful glycine and histology. Secondly, CRM, radial margin positivity, it's the highest impact adverse factor in rectal cancer. As is application in colon cancer, but particularly important in rectal cancer. Optimal and best way to assess the CRM is using the Quirk method. Thirdly, extramural venous invasion. I argue that extramural venous invasion, update that's been made in the most recent 2016 version of the CAP checklist, is the most important change or update in that CAP checklist. Even ahead of serosal invasion and CRM positivity, because extramural venous invasion appears to be as important a prognostic factor as lymph node mets, and it's seen more frequently. You should be reporting this in at least 30% of your cases. Recommend routine blast and staining to do it. Poorly differentiated tumors. You see one. Consider the possibility of microsatellite instability. Take the difference between a high-risk clinical stage 2 and low-risk clinical stage 2. Actually, tumor deposits. Obviously, it's a moving target. I'm told that TNM7 was really supposed to be a vehicle for collecting data for tumor deposits so that we can understand them better. And so we eagerly await TNM8 to see what exactly we have learned from that. So I'd just like to thank you for your attention and would welcome any questions.
Hi, Parfitt. This is Shireen. Thank you very much for an excellent presentation, and thank you to everyone who has posed questions. We do have some questions for you. So the first question that we have is from River Hospital, and would like to know if the tumor is proximal to anterior reflection and distal to posterior reflectium, what should be the location, rectal or rectosigmoid?
That's a good question. Obviously there is some difficulty, that rectosigmoid junction is. I know that in the CAP checklist they'll state that you can identify it by observing where the tinea coli fuse into the longitudinal muscle layer of the rectal wall. I think that sometimes is difficult to find. What we do here is that if you have that between the anterior periflexion but below posterior peritoneal reflection, we regard that as a rectal cancer, an upper rectal cancer rather than sigma.
Okay, our next question is from Grand River Hospital, showing 40% signet ring component. Should we still call it high grade, or since it is less than 50%, is it still low grade?
Is a good question. According to the definitions provided in the CAP checklist, to make it a signet ring cell carcinoma, it should be more than 50% signet ring cell. However, it really depends on how much glandular architecture there is too. To that question, it's only 40% signet ring cells. It wouldn't actually be pure ring cell if the rest of it was glandular architecture. It possibly might not even qualify for high grade. But in that situation, the important things are to consider the possibility of microsatellite instability, and show signet ring cell features and intratumoral heterogeneity. And whatever you do, I would put at least a comment that there's a significant proportion. You can list the percentage that shows high grade histology, and comment that it would be will likely behave on the basis of that high grade component.
Thank you much. Our next question is from Dr. Yangar from Trillium Health Partners. Although not pain serosa is indicated to avoid confusion with true margins, I'm interested to see that most of the examples showing LPI in your presentation did show ink on the serosal surface. Does it help to see tumor cells touching the painted surface to call P4A, especially in clefted areas? That's a couple of questions from Trillium. That's the first one, so I'll let you answer that first.
It's a good question. I thought some participant might spot that in the photos I provided there actually was some blue ink on the serosal surface, which is because locally at our own institution, we for local and traditional reasons, we do put ink of a different color on serosa. I think the main issue here is that if your pathologist assistants, if pathologists who are grossing, if your residents understand very clearly the issues around serosal invasion and are able to make their, are well trained to make their assessment of the macroscopic fecal invasion for inking it, then it's probably, no real harm in applying an ink of a different color and clearly stating that in your report. But it's just very important not to do that without a high level of awareness of the need to assess the serosa and where those suspicious features might be.
The second question is, how do you approach a cellular mucin in lymph node, not neoadjuvant cases? Do you do levels and keratin staining? Do you call negative nodes if no epithelial cells and add comment?
Sorry, was that in the neoadjuvant or the non-neoadjuvant setting?
Non-neoadjuvant cases.
Okay. Certainly that issue is a lot more common in the neoadjuvant setting of rectal cancers, where you may have mucus pools showing up in a lymph node. That's been well documented, and the guidelines are very clear there. That acellular mucin should never upstage, a TN or CRM or anything. There's not a lot of information about how to handle that in the non-neoadjuvant setting. I've rarely encountered that problem ourselves, and it's rare. It does rarely occur, and what we would do in that situation is we typically perform step sections right through the entire. And if in the end we're not able to demonstrate tumor cells, we would not call it a lymph node met, but as the caller yes, we would handle it in a comment that there's acellular mucin in a lymph node. We would assign that in the N category. but there may be an increased risk of a higher, stage in N category.
Great. Questions. Why is LVI versus venous invasion not separated out in the CCO synoptics? And why is there no separate category for extramural venous invasion? Do you do routinely upfront or only based on H&E suspicion?
That's a good question. As I mentioned, in the 2013 version, the distinction between lymphovascular invasion and venous invasion was omitted, and certainly a glaring omission that's being resolved in the 2016 version of CAP checklist. And that's just at the end of January of this year. So you will find in the updated version both lymphovascular, venous invasion, and then for venous invasion, separate fields for extramural venous invasion versus intramural venous invasion. So I think that has been resolved. And what might constitute a routine staining protocol, it's variable. There's hard and fast guidelines. There are some institutions that I know are doing routine elastin staining on all cases. In my own practice, what I've kind of reduced for the time being is the important extramural venous invasion. I'll do routine MOVAT stains in all PT3 and 4 cases in the deepest tumor invasion. And of course, any other cases that I suspect it on based on an orphan artery sign or something like that. I would do it on all PT3 and 4 cases in some blocks, even if I may not see those distinct orphan artery or protruding tongue signs. And many times I've certainly picked it up. I'm kind of surprised by doing that.
Our next question comes from Amir Samani of Brampton. 2016 archives paper shows that PT3 colon with positive elastic layer invasion does the same as PT4A. Positive PLI is a significant predictive factor for lymph node metastases and recurrence-free survival in PT3RC. This indicates that PT3 tumors with PELI should be treated like PT4A tumors.
Oh, is that perhaps a comment then rather than a question?
I'm sure it was posed as a question, but it could be possibly a comment. I don't know if you want to comment on this at all.
I'll just sort of reiterate that that's interesting. That there's a 2016 paper that's that we could perhaps add this portion of the slide. It does add some perhaps increased weight to potential for the elastic lamina as a surrogate marker for serosal invasion and separating out T3 tumors. That's fair enough. I would just reemphasize that according to the current guidelines, the CAP 2016 guidelines, which actually don't even mention this issue, the PAT does discuss the issue, but recommends not to do it at this present time. And again, there are just some practicality issues about how this would be done. It seems that in a proportion of cases, it's either difficult to assess the elastica or is absent. How many tissue blocks. There are enough questions, I think, around it that we would recommend sticking with the current guidelines and you take a wait and see approach.
Our next question comes from the University of Alberta Hospital and Dr. Julian Bani. Is there data to show is added prognostic information if the case already has known lymph node metastases?
Okay. That also is a very good question, and interestingly, I can sort of locate that. The answer to that is yes. A study so far that last undetected venous invasion has shown to be predictive both node and node positive disease. So we mentioned that in the formal part of the presentation. That's a good point. It's not only as strong a prognosticator as lymph node mets, but it seems to be predictive in both node negative and node positive disease.
Our next question comes from Roz Circa. Are you reporting tumor budding?
I hope somebody would ask about tumor budding. That's another sort of favorite topic for everyone, I'm sure. Tumor budding, there is some growing evidence that this is an independent predictor of poor outcome. In particular, it seems to be predictive of lymph node mets and tumor progression. I would say that it is not currently recommended in TNM7 CAP Protocol 2016. Neither would even mention it. If you do a search for budding in the CAP list, it doesn't come up. The OPAT dataset discusses it, but doesn't. We don't routinely assess tumor budding in cancer resection specimens. We've only recently just started to attempt to assess it in a malignant polyp. So this is really a totally different context. It seems to be predictive of lymph node mets, markers that might be a reason for a formal resection following a polypectomy. So we don't do it in resections, but we've just begun to do it in polyps, and it's just not recommended so far in the guidelines. There continues to be a number of questions remaining about methodology and reproducibility.
Very much. Our next question comes from Karen, and her question is, how should we report cases to CCO if we find less than 12 lymph nodes in a specimen submitted with minimal adipose tissue?
Okay, so the question is regarding lymph node yield, and certainly the benchmarks TNM7 and CAP and RCPAP are all basically in agreement that you should have at least 12 lymph nodes, and really it's apparent that that's kind of a lowball figure for what we should be achieving. If there's a reduced number of lymph nodes on the basis of poor surgical quality, then I think you count the lymph nodes you have. You perhaps follow whatever local protocols you use in terms of if you have less than 12 lymph nodes. Here, what we tend to do is use a lymph node highlighting solution. So if we have less than 12 lymph nodes, we'll put this GOOF solution, glaciatic acid, ethanol water, and formalin, and that solution overnight, and then reassess it next day. At the end of the day, you've got less than 12 lymph nodes. I think you just list what you've got, and presumably, if it's a rectal cancer specimen where you're also commenting on quality of the mesorectum, will be communicated in that part of the report as well.
Great. Our next question comes from Celia Marginian. And the question is, if two separate colon masses 10 centimeters apart, are they considered two separate primaries or multifocal carcinoma? Do we need two synoptic reports?
Okay, that's a good question. I think it constitutes multifocal disease. I think you would probably put the prefix for multifocal in case. Multifocal disease is not, to my knowledge, specifically distinguished, as a separate term from stating there's more than one primer. I think they basically mean the same thing. What we tend to do here, just for practical purposes, is we avoid using multiple synoptics as much as possible. Our synoptic reports are very long as they are. The practice of sticking synoptic on synoptic is very unappealing. What we tend to do is we populate one synoptic report with the highest, stage items from each tumors, and then we'll handle the nuances for, which in comments, either throughout the report or at the end of a report, however done. But to, as much as possible, try to use one synoptic report.
Much. Our next question comes from Dr. D. Filipenko. As for extramural venous invasion, how much elastin stain do you require to call it positive EMI?
That's a good question. I think the guidelines thus far really that you want to see, that really would like to see circumferential meaning around a tumor focus, like an enclosed ring. Had 7/8 of a ring, then it becomes use your judgment. That's probably good enough. If it is possible to have linear arrays of elastin out in the subserosa in particular that don't necessarily signify a vein. So I would exercise caution if it's not a completely enclosed ring of tissue, and then look for other things too. Sometimes you can identify a muscle coat. I've faced one case in my own practice where I failed to identify an elastin layer around an extramural vein, but able to see convincingly muscle all the way around it. So the diagnosis could be made on that basis too. If you have a ring elastin, it becomes particularly compelling, but in the end, it's a bit of a judgment call.
Thank you. Our next question comes from Dr. Rosemary Henderson. Do angular pools of mucin that are deeper than clear invasive tumor change the P stage? And this is with no adjuvant therapy.
Well, again, not a whole lot of guidelines out there that specifically address that issue. But I think you do two things there. I think you use the information that we have in the adjuvant setting, where acellular mucin pools do not upstage anything in the absence of viable tumor cells. And if you take basic TNM philosophy, which is stated in the AJC manual, where there exists uncertainty, then you opt for the lower of the two stage category possibilities. So if you had, mucin, acellular mucin extending into, say, the subserosa compartment in an T2 tumor, set levels. You might bring up spare tumor cells to resolve your problem. But if at the end of the day you're with acellular mucin, then I would not upstage it. Handle in a comment that there's acellular mucin doing such and such. It's possible that the gift stage designation is an underestimate, and I think that's the best you can do.
And we have some additional questions on tumor budding, and you might answer some of these questions, but I'll just read this out. This is another question from Dr. Amir Samani. Do you report on tumor budding, and what criteria do you use? Well, in the context of colorectal cancer resection specimens, which is really what this presentation is about, we don't routinely report tumor budding. Again, doesn't appear in any of the guidelines at this time.
In context of malignant polyps, which I think is probably the most promising context where studying might be applicable, just starting to do that, and I'll just say that with some degree of and we don't specifically adhere to any specific guidelines because I don't think there are really clearly widely accepted guidance for how to do that. There are some available, and it's kind of on the context of this talk, but that's how I would, I guess, answer that question.
Great, very much. Our next question is from Dr. Jeremy Daniels. I was wondering how often you call complete versus nearly complete versus incomplete TME in your experience.
Well, that's a difficult one because it really depends on your surgeons. So I say that, and I don't have exact numbers or statistics in my head, but my stalled experience locally from having quality rectal surgeons at our institution is that we mostly call things complete and nearly complete. It's less common for us to call something, frankly, complete. Really, that really is going to depend on your local institution and the specialized skills of the surgeons there.
Great, and just a couple of last questions here. The next one is from Dr. Fawaz Halwani. How do you grade a mucinous carcinoma? Is it graded by its MSI status?
A mucinous carcinoma is a special type of mucinous carcinoma. So, or a special type of carcinoma defined as more than 50% mucinous differentiation, it qualifies. Having said that, non-mucinous carcinomas are the same. Sometimes glandular architecture, and I think you could fairly call it, low grade if there's more than 50% glandular architecture combined with extracellular mucin. That lacks glandular architecture, then I think you could have low grade or high grade mucinous adenocarcinoma, depending on the glandular architecture of the cells, floating within the mucin pool.
The question is from Pratibha. Based on current CAP checklists, do you use the contour of tumor nodule in perirectal fat to determine discontinuous tumor deposit versus involved node, or do you call all nodules without residual lymph node as discontinuous tumor deposit?
Okay, well, in the current guidelines, there's residual lymph node tissue, lymph node. It's not according to the rounded contour rule. Was TNM 6, but use the residual lymph node tissue rule to make designation. Having said that, what constitutes residual lymph node? This is only a messy area. I cited that paper where a panel of experts were using a rounded contour in their estimation of what constituted residual lymph node tissue. Personally, I would like to see either a subcapsular sinus or peripheral rim of lymphoid tissue, preferably with a lymphoid follicle, to be able to call residual lymph node tissue. I wouldn't rely on the rounded contour rule, and that's certainly not discreetly mentioned in TNM7 either.
Thank you much. And we have another question from Dr. Amir Samani. Invasion of colon carcinoma directly from transverse colon into omentum, is it PT4A or PT4B, omentum is a separate structure?
Right. Well, that's an example of where there's probably going to be both serosal invasion and invasion of an structure. So I think what you would do there is you would call it PT4B on the basis of the invasion of the adjacent organ and structure, despite the fact that there's also serosal invasion. Just keep in mind the one caveat that if you have that's grossly adherent to adjacent organ or structure, case omentum, important to demonstrate tumor within the adhesion histologically. I may see it grossly adhere to and suspect T4B disease, but it needs to be refined based on histology. You need to see tumor actually within the adhesion to call it T4B.
And our last three questions, the first of Dr. Sean Gui. Regarding the elastin stain, do you have suggestions on the minimal number of sections to be performed on?
I would say there are no hard and fast rules there. I think tend to do here locally is perform it on sections of deepest tumor invasion, which is probably the most likely spot you're going to see extramural venous invasion. So in a case, you're probably going to take 2 to 3 sections of the tumor at the point of deepest invasion, and I would routinely perform elastin stains on all of those.
Last question, there's a two-part here, and it's from Dr. Julinar Baisani of the U.S. Once again. And the first is, what made your group start to adopt reporting of tumor deposits in the setting of malignant polyps?
Sorry, repeat that question.
Made your group start to adopt reporting of tumor budding in the setting of, or is it, tumor deposits in the setting of malignant polyps? I think that's his question.
Okay. Well, the question is a little bit off topic, I think, for this talk, but I would say that there is evidence that is reasonably compelling that tumor budding is predictive of lymph node metastases. So in the setting of malignant polyps, you're looking for variables that predict particularly tumor recurrence or lymph node metastases to tell the surgeon whether a formal resection is needed. Consider the variables lymphovascular invasion, poor differentiation, and margin status, the conventional things. But would be a natural fit there. That's why we started to do it. It's a local decision. It doesn't mean that it's really achieved kind of prime time status. Obviously, the guidelines aren't even mentioning it yet.
And yes, and that was, he had an add-on to that. Is there benefit in reporting tumor deposits? It already has lymph node metastases.
Is there benefit to reporting tumor deposits if there's already lymph node metastases? So that's thinking about in the context of a colorectal resection specimen, I guess, rather than a polypectomy. Yeah. And, I don't know the answer to that. I haven't carefully reviewed the literature enough to be able to a common answer for that.
Great. Just one last question from Dr. Leanne Wijanarko. How do you differentiate the free-floating tumor cells than a pickup?
Actually, that's the concern, right? Is if you have free-floating tumor cells, could it just be content or pickup? And I would say that in Shepard's papers, both in a study in a 2005 follow-up review paper, I think in histopathology, they addressed that, they discuss it, and they defend it based on their clinical follow-up data. Intuitively, it seems difficult. I think the things to commend it are that if you have free-floating tumor cells into a serosal reaction, a serosal erosion or ulceration or some kind of mesothelial hyperplasia, then that itself is suggestive that there's something going on with the serosa. And again, just trust the studies. You know, that's what they use in their studies, and they have very compelling clinical follow-up data. It seems that those lesions are, you know, the highest risk for peritoneal recurrence.
Thank you very much, Dr. Parfitt. Dr.
Yes, thank you.
Thank you. Welcome.
I'm with Cancer the Partnership Against Cancer and for the great presentation today. The number and breadth of the questions really session second series of checklist presentation your for ways to ensure these sessions are your practice your completed online evaluation. This is a WebEx recording of this will be available for wide distribution via links posted to Cancer Care Ontario, CMAC, and the and not restricted. As a reminder, both the live and recorded presentations are eligible for continuing education credits. Please see the session notice for more information. The CME ECAP education checklist sessions will only be the presentation date. The session will remain available electronically for time, but CME certificates will only be issued for 1 month. Please refer to session notice for the exact deadline date. And our next talk will be given on March 30th for Boyna Georgievich, who will bring us an update on the ovarian ECC checklist. Thank you.